Good morning, everyone. I'm Jill Chadwick. I'm clearly not Dr. Steven Stites. He is a medical professional, and as that is true, he has an emergency he's attending to right now. He does anticipate that he will join us, and then we're just going to play musical chairs. I'm going to get up, and he's going to come back in and take over. But right now, I'm driving this train, and so what I want to do first is go to Dr. Dana Hawkinson, who is out in Colorado, and let's get an update of the numbers. And Doc Hawk, you look amazing this morning.
Yeah, hi. Can you hear me? So was able to get a good night's sleep and a nice shower after camping out in the wilderness, and it was good. Numbers for today in the hospital are 23, but I think the main issue is that we've had some discharges. Unfortunately, with those 23, I think we had 22 yesterday. We've had just the same number or as many admissions. So I think that's the big story here. We have had the same 19, 20, 21, 22 for the past week or 10 days. But I think the real issue, today and going into the weekend is that even though we've had a large number of discharges from the hospital with COVID, we have had just as many, or if not more, admissions with COVID. And so I think that's the big story, and that's the big thing we really have to be concerned about.
Well, that is kind of discouraging news to hear this morning. We will check back in with you in a little bit and ask you some more questions, and we appreciate that update. All right, in studio with us this morning are two guests here from the hospital. To my left is Colette Lasik. She's the Vice President of Revenue Cycle. And to my right is Jason Grunstrom. He's the Executive Director of Continuum of Care. And today they're going to help us walk through some of these and navigate some of these costs that are related to COVID care. We know a lot of people are suffering both from the disease and also financially, and these two experts are going to help us and help you navigate some of that. But first, we have one more bit of crisis communication today, and for that we're going to go to Jessica Lovell, who is over at the KU Med Center, and she is going to tell us about a blood drive, and I'm getting waved off. We're having a little bit of technical problems this morning. Can I get a big thumbs up on that? All right, we're going to come back to Jessica in just a moment. Colette, let's start with you. We know that COVID has impacted the work that your team does. Explain to the people that are watching what your team is, what the work is that they do, and how COVID is impacting you.
Yeah, I appreciate that. And again, our team is what we call revenue cycles. So when you think about a health system, we create revenue by seeing patients, right? We've been doing that for 100 years. And what's really important to us is that we take great financial care of our patients. So we do that every day. We do that through our financial counseling staff. We do that through a third-party vendor that we have here to help patients in need that might need to help get onto Medicaid or other programs. And we also want to make sure that we have things in place to help our patients every day. So you're right, Jill. I mean, today we're hearing from more patients probably than we ever have because things have changed. Maybe they don't have a job for the first time that they've ever known in their lifetime. Or perhaps they're laid off and they don't know when they're going to go back. So when patients get that bill and they're scared or they're upset, we want to hear from them. We've got a call center, a financial call center that's open from 7:30 to 5:30 every day. Patients can always contact us via MyChart and know that we're here to help. And we understand that your situation may be totally different today than it was a week ago. And if it is, call us. We're here to help.
I know that 10 years ago I came to this hospital as what I call a dumb news reporter because you don't know what you don't know, right? And I know that from that experience, I started learning about things like codes. Tell us how codes drive the billing process. What is a code?
Yeah, that's a great question. So like everything in technology today, we talk to our insurance companies in codes. So they're national codes. We have procedure codes that tell them I did this procedure to this patient. And then we have diagnosis codes that tells them, and this diagnosis is what happened with this patient while they were here. So with COVID, we got a whole new set of 100 plus codes to be able to talk to our insurance companies. But we literally have tens of thousands of codes that we use every day. And that's a national standard that all healthcare providers use to talk to the insurance companies, because we do that electronically in binary code. I mean, it's basically old binary code that we use, but that allows us to get our information on a claim to a payer real time. So as soon as we have all that information ready, we can send it electronically to the payer. They can receive it electronically. They can adjudicate the claim and then send us actually the payments and all the information on the claim electronically, and we post that to our system. So with COVID, as Jason will talk about with telehealth, it's just really expanded that set of codes, and it's changed very rapidly. CMS has changed the rules on us virtually weekly as they were learning and setting up new codes for all the other insurance companies to follow.
As one of our doctors said, we're building the airplane as we're flying
Exactly what it feels like.
And so I'm going to fly right over here to you. And I was astonished when we were talking about telehealth medicine and setting it up. You said that there were 135 new codes just for that?
Yeah, that's correct. You know, one of the things that we closely look at is CMS and what they kind of come out with telehealth every year, telemedicine. You know, we're always interested in some of the new codes that they come out with every year, and sometimes they're a little slow on the uptake. We were astonished with when the pandemic came across back in March, how quick they were to respond with new codes. I think for a number of reasons. One was to really make sure that our patients felt supported. Their patients felt supported. You know, I think 40% of Americans that we know have some form of Medicare, and they came out quite soon in early March with 135 telemedicine codes, and really paid attention to not only those who had broadband access, but those who did not have broadband access. I think 85 of those 135 codes were specific to just telephone, really reaching rural America, where we know there's a lot of people who don't have access to broadband or do have a cell phone plan, but it costs data, and they get nervous about losing or being charged data plans when they're using video. And so we're very excited, watching what Seema, the director of CMS, said 2 weeks ago, is that these 135 codes look like they're going to stay around for a while, and we're very excited about that. I know a lot of our patients were nervous and were asking us about that. Even with Laura Kelly, our governor, she extended the payment for Medicaid here in the state of Kansas to the end of January of next year, which has been a true blessing, as we know that a lot of people have been contacted by their insurance companies that it's ending here soon. And for our governor to come out and do that, I think in the conversations we're having with insurance companies, they're going to extend that as well. And so more to come, but love to see some of the movement we've had, and the calmness of fear of, hey, if I'm seeing my physician or provider via telehealth, will this be covered? And great news it has been.
Yeah, that's a big milestone, correct?
Big milestone.
Right.
Absolutely.
And the other big overarching message is, if COVID-19 is the primary diagnosis, it too is being covered by insurance companies, you're finding?
Finding, yes. And we heard early on from most of our payers that they were going to follow the CMS guidelines, meaning that they were going to process those claims where COVID was the primary diagnosis or screening, that they would not be applying deductibles and copays to patients' plans. So we're watching that closely to make sure that that does hold true. We've had some that haven't, and we've had to make those calls to those insurance companies. In fact, we just met with one of our major payers yesterday and said we're having problems with these. So that puts a lot of burden on us, because we want to make sure that patients don't get a bill that they shouldn't. So part of it is making sure that we're holding insurance companies accountable, and that they've got their system set up in a way, because again, they've had to change on the fly too.
Right.
To make sure that their systems are set up to recognize these claims when they come in, so that they process them and not apply deductibles or copays like they normally would.
I imagine, because we're also full, that you have other business besides COVID going on.
Just a
so
little.
if someone can't get through, whether it's here or at another, wherever you are getting your health care, are these kind of counselors available and information? What is your advice, just overarching, to people that are in this situation?
Yeah, absolutely. And I've actually been talking with my counterparts across the city over the last month, and just really talking about what are they experiencing at their hospital. It's the same as here. Very quickly, they heard from patients, probably within the first week of COVID, of, hey, my situation's changed, I need help. And we all have financial counselors on staff. We're all here to really help those patients. And even if a patient starts at another hospital and they've started a Medicaid application and they come here, we can help, and vice versa. That's something that we've done in this industry for a very long time. We're all here to take care of the patients in our community, not just clinically, but financially, because these patients do go back and forth between health systems.
You have a great quote that I always quote you on, and I'm sure it's true for anybody that's in the medical profession. You know, the worst thing you want to do is give a patient great care and surprise them with the bill.
And surprise them with the bill. To me,
Right.
that's one of the worst things that any of us can do. So I think as an industry, that's something that we're working really hard to try to change. How can we take all the information about your insurance, Jill, and where you're at in your benefit plan, right? Have you met your deductible? Have you met your copay? What services are we expecting you to have as best we know? And then be able to give you a good faith estimate up front of what we think you're going to owe and what your options are to make those payments.
Right. I will tell you, Colette taught me another lesson too, and it's, I bet you know your car insurance better than you do your health insurance, Jill. And I said, could be, but it's because it's a lot more complicated, right?
It is a lot more complicated.
But you have empowered me, and that's what we're going to try to do this morning. Before we continue this conversation, though, I see Jessica Lovell. I can see her now, and she has a really important message for us. We are having a huge shortage of blood here in the metro, and she's going to show us how safe. We've talked about how safe it is. She's going to show us how safe it is. Jess?
Hey, Jill, good morning. So good to see you and hear your voice this morning. So we are here to show you how easy, how quick, and how safe it is to give blood. So I want to bring in the expert here with the Community Blood Center. This is Diane Newbecker. And see, we keep encroaching.
I know.
We got to keep our distance.
Got to keep the 6 foot.
That's just one of many safety precautions we're taking. But we're going to I'm going to sign up and give blood here in just a moment. But I want you to walk us through the process so folks out in the community know how easy it is and also how safe you're making this in this time of COVID. So tell us what this first step is.
Sure. So we put in a pre-screening area just for COVID purposes as an exterior precaution. So we check if you have appointments. We have a couple of pre-screening questions. We take your temperature, provide a mask and water if you need it. And then we go to our regular process, which is registration.
Okay, so we'll show that. And water, while we're talking about water, is that something you should be doing at night before you come in?
You should be doing it the day before and the morning of. You should have eaten really, really well.
Okay.
Iron-rich foods are preferred so that you have a good experience.
Okay, so let's walk in here. I'm going to have Nick kind of walk us in. So this is what you would normally do when you come in a non-time of COVID.
Right. This would be the first
step. Get your
step.
registration. So tell us what's happening in this step.
So they register you. They ask you your name, address, phone number, if you've been with Community Blood Center, if you donated before. And then they just give you a tablet with a bunch of questions on the questionnaire.
Okay, and then you're going to step over here to these little screens over here and answer those questions on the tablet.
Right.
That takes how many minutes about?
Maybe less than 5, probably.
Less than 5, okay.
Yes.
So then you're going to walk down here.
You'll give the tablet back to the receptionist.
Okay.
And then, yes, we walk down here and we're going to do the medical histories.
Over here, straight ahead, back there, where we're going to see some different testing that's going to happen over there to make sure that it's okay for you to give the blood.
Right, so we want to make sure that you are eligible to donate. So we're going to do, we're going to take your temperature again, we're going to do blood pressure, and we're going to ask you screening questions and take your hemoglobin level. That's important to make sure that you qualify.
5 or 10 minutes for that too?
Yeah.
If that?
Yeah.
Okay, and then here's where the magic happens.
Right, the magic.
And you say you're only here maybe 7 to 12 minutes? I thought
7 to 12 minutes. Yeah, so this is probably the shortest amount of time is actually giving blood. And of course, we take all the safety precautions necessary, and we've always done that, but we added a few. We do extra cleaning, sterilization. Our staff does have to get close to you during this process, but that's really the only part that we really don't maintain our 6-foot distancing.
So numbers have been down because, as expected, people are concerned about going out anywhere at this point. So now you're wanting people to come back.
Right.
Are you seeing those numbers come out? How important is it for people to come out and give blood?
It's extremely important, and what's happening is our businesses are canceling their mobile blood drives because they don't have their staff back. So we are not getting those drives back. That's thousands of units that we're missing right there. So we're trying to make that up with doing large venue drives and that sort of thing, but we still need a lot more blood drives. So if there's any community organization, churches out there that are willing to do a blood drive, please do. We are at a 3-day or less inventory for blood products, and we like to have a 7-day. So we're very, very urgent need for blood. If you've ever considered giving blood, if you're healthy, please come out and give blood.
Make an appointment. You said that's
Make
really
an appointment is what we prefer. We do take walk-ins if capacity permits.
Okay.
And that's just helping to maintain the social distancing and so forth.
So then after this step, you have to come over here to my favorite part, which is the snack table.
Yes.
So Jill, I'm going to sign up and give blood here in just a minute. I'm going to go through this, and at the end, guess what I get? Better Butters. Best part of the day.
Yeah, well, we have all refreshments, Oreos, pretzels, Nutter Butters. We want you here at least 10 minutes just to recover, and then you're free to go after that.
All right, sounds good. We'll check back with you, Jill, at the end of the show.
All right, sounds good. You and I think alike. Nutter Butters, my fave. All right. Do we have any questions from the media this morning? If not, then we're going to go right to our community questions. And Dr. Hawkinson, this is going to be for you. And this is Nancy, and she wants to know, is there any hope or proof that having a very strong immune system can help prevent getting the virus? Or if you do contract it, if you're not having too many symptoms, so can it make it less? She says she's not been sick in 10 years, she's healthy, and the reason she's asking is she wants to go traveling.
Yeah, I wouldn't use that as our main reason as to why we think, we can travel or take a license to not do the things that we've been talking about with masking and hand hygiene and not touching your face. You are still susceptible. Everybody is susceptible to this virus. We don't really have a grade of immune system, whether you have a strong immune system or a weak immune system, unless we're talking about obviously like cancer patients and other people who are immune suppressed due to certain types of drugs or health conditions. But otherwise, we don't really have a grading system for someone who has a strong immune system or a weak immune system. Everybody needs to continue to take these precautions of what we have been talking about, the pillars of infection prevention, especially for coronavirus, because really everybody is going to be susceptible. Get further up in age, over 50, over 60, over 70, the likelihood that you will have symptoms and have some immune response to this is greater compared to, say, if you're 20 or younger, where they have shown that, generally many of those patients will have less or no symptoms.
Do we know the demographics of the people that are currently in our ICU? Are they older, younger? Do they have underlying health conditions? Do you have that information?
I don't have that information. I'm sure, we could get it. Again, we have seen in the ICU, but in our hospital as well, I have taken care of a 27-year-old otherwise healthy female. We have seen in our ICU, there have been a range from 20s to 30s, obviously, to 60s, 70s, 80s. But currently, I don't know the demographics of the patients that are in our hospital or needing critical care services in our ICU.
All right. Lindsay wants to know, when you give numbers of positive COVID patients each day, is that only COVID patients with no other illness who have tested positive in a procedure, prior to a procedure, just coming in sick, COVID diagnosis? What do you know about that?
Yeah, absolutely. Yes. So we are screening all of our inpatient admissions. This includes people who are admitted for surgeries. This includes trauma victims who come in. We are screening all of those people, as well as obviously testing people who come in with symptoms. Those numbers that we talk about are just all of our patients that are in the hospital for one reason or another that have tested positive. I should note that most of those patients that we talk about are coming in for COVID specifically. Typically, what our average number of people that we have just found COVID for who come in for certain other reasons is typically about one a day. So the numbers on patients that have COVID symptoms are certainly the majority of the patients that are in the hospital. There could possibly be one or two that are just here for another reason but have tested positive for COVID.
Are the reason that the numbers are climbing and positive because we're doing more testing?
We are doing more testing, but we've also talked about the percentage of positives. So even though that we're doing more testing, the actual percentage, the number of people that were getting positive has certainly increased from, say, where it was 2 months ago or 6 or 8 weeks ago, just because we know the virus is out there, it's spreading. Even Dr. Fauci has said, well, now we think we are seeing that surge that originally we thought for Memorial Day. We are thinking we are seeing that now. And again, more people are out there. It tends to be, 7 to 10 days that people will start seeking treatment after development of symptoms, for the most part. And again, that is a lot in part due to the inflammatory response, the immune system response from the virus itself.
All right. This one would be for you, Colette. Is testing covered? Is COVID testing covered?
Is COVID testing covered? I would say in general, yes. Most of our insurance companies have told us, along with CMS, that if it is for screening, that they will cover those tests, yes.
And I had a person, and I'm trying to find their name, but they had asked earlier on a previous broadcast, they had asked if are multiple tests covered. So, I'm because the test doesn't last, but for, a day or two. The results, rather.
Yeah, no, that's a valid question. We're just starting to get into that, especially with colleges starting to look to go back to session, and we've got ball teams that are starting up. So those are questions that we've actually posed to our insurance companies. Just yesterday, we had that question with Blue Cross Blue Shield to go back and say, how often will you cover this? And so we're just starting to get into that.
Here we go, flying the airplane and building it as we go.
Exactly.
We'll check back with you then at some future time on whether that is going to be covered. Christy wants to know, Dr. Hawkinson, a suggestion on when to get the flu shot this year. She said, I usually wait until October because of how long it lasts. Should we get it earlier and get a second flu shot at the end of the season?
That's a great question for vaccination in general. And we've always continued to be a proponent of vaccination. We feel that with COVID, especially with pediatrics, people are missing out on their normal vaccinations. So for influenza, and especially for my HIV patients and other patients, I've always advocated for, say, October, early November, depending on how early the influenza season starts. And just as she had said, it's because we want it to last. So typically, the strongest immunity for influenza vaccination occurs about 2 weeks after getting the vaccination and lasts for about 6 months. So lately, we have seen that there is a longer stretch of the influenza season leading further into the spring than normal. So certainly this year, I would continue to advise at this point in time to get it in, say, late October, early November. But the main point here is also, if you're otherwise seeing your physicians, we never want to miss an opportunity to vaccinate. And certainly it's greater now with all of the private clinics and the pharmacies able to give influenza vaccine. But I don't think that you need to wait any later. I still think October to early November is a good time to get it. And right now there is no FDA recommendation for getting a booster influenza vaccination. And that is a question that comes up regularly, that has been studied and continues to be studied. And we, the people doing those clinical trials and looking at that will continue to evaluate that and giving an adequate answer. But right now, there's no need for booster for influenza vaccines.
I'm just curious, no one has written this, but do you think that because of all the social distancing we're doing and the attention to wearing masks and sanitizing our hands, is that going to make flu season better this year, maybe?
Yeah, I think they saw a little bit of improvement in influenza rates in a couple Asian studies. I don't remember exactly which countries. However, we are hopeful that continuing to do all these things to help mitigate coronavirus infection and spread will also be very effective in helping reduce the common cold, the common coronaviruses, rhinovirus, metapneumoviruses, all those types of mild cold illnesses, but also influenza. So, that may be a silver lining. We are really optimistic that will happen this year as well.
Gene wants to know, he apparently knows somebody who's going to a wedding in Wichita, And he wants to know, even though that person is going to wear a mask, he's not confident everyone else at the wedding is going to be appropriate. It is an outdoor wedding. His question is, do I say socially distance from that person going to the wedding when they return for 2 weeks?
I think continuing physical distancing as much as possible is the best thing. Obviously, if they live in your household, that's a very difficult thing. Right now in Kansas, there's no mandate or restrictions on in-state travel, so I don't necessarily know that you have to do that. Certainly be aware, however, after the person comes back, and see if they have been contacted, that there's any new cases or any cases that have sprung up from that gathering itself. But otherwise, just continue to use your best judgment. If you can stay physically distanced from that person or interactions outside, that is probably best. But that's in general what we would recommend for really anybody who's traveling or going to be at any gathering. Certainly, I think that being outdoors is going to help a lot. I don't know what the reception situation will be, but in answer to the question, just continue to do what you would do. If you can physically distance, that's great. Obviously, if they are in the household, that's going to be a little bit more difficult.
Donna wants to know, has there been any discussion about reporting numbers in more categories than just positive? And specifically what she's asking, how difficult would it be to report total new positives or positives without symptoms? Or do we have any data on percentages of that?
Other than the large studies that have been published, to answer her question directly about patients who are positive without symptoms, unless there's widespread testing or everybody getting tested once a week or every day or every few days, it's hard to know. Certainly in places, congregate living like the prisons, like nursing homes where there's outbreaks, where there is contact tracing and testing being done on a regular basis, we can really understand the numbers that are testing positive, that are asymptomatic. But again, are they just asymptomatic at the time of testing and are really pre-symptomatic so that, 5 or 6, 7 days down the line, they'll have symptoms? That is something you have to retrospectively look at as you go back in time to look at all that information. So sometimes that can be done, especially in the context of a research study. But in general, in real time, that's probably a little bit more difficult to do just because of the reasons that I've talked about.
All right, I got 2 or 3 more questions for you. Then we're going to talk with our guests in here, check on Jessica, and you be thinking about your final thoughts. But first,
Okay.
Cindy wants to know, she says, I have lupus, and I have a wedding in Wichita on July 4th, and I'd really like to go back to my water aerobics class. I'm a little scared of both.
Yeah. Yeah, again, difficult situation. We come in that is run by us. I think the wedding, as we had talked about before in the earlier scenario, if you can do a wedding outside, if you can physically distance, obviously wearing a mask is going to be very important. We would recommend that. You have to look at that situation. The reception, whether it's indoors or whether it's outdoors, that's important. Can you continue to be physically distanced from other people? Because that is really the main points of all of our talks is the physically distance, wearing the mask and doing the hand hygiene. The water aerobics, I think that will be, possibly a little bit more dangerous depending on if that's taking place inside versus outside. Again, we have never really been worried about the virus if it goes into the pool or it goes into the lake or the ocean. It's really the proximity to other people and the closeness for a certain amount of time that can spread the disease. If you can go to a pool, especially if it's outdoors, and you can be doing water aerobics and you guys are 6, 8, 10 feet away from each other and that can be done safely, I think that's certainly a reasonable thing to do.
Linda wants to know about blood types and the susceptibility. Does a blood type make it more susceptible to COVID?
Yeah, that's a good question. I anticipated this question a week ago. There was certainly a large genetic study where a group from Italy looked at, I think it was Italy and a couple other different European countries, looked at patients who were severely ill in the hospital, who were otherwise in the hospital and ill, needing just oxygen and not ventilatory support. And they ran it through a large genome database. And what they found was that there's a possible association at an area where the blood type is on the genome. And this was more for patients who were severely ill on the ventilator compared to patients who had COVID compared to patients who didn't have COVID. And there was a skew towards, I believe it was type O or type A. I don't remember exactly. But in those severely ill patients, they did see a skew towards one blood type. However, when they also, in the same paper, in the results, when they looked at patients who just required oxygen, there was no difference in blood type. And so this is a very good observation. I think more studies need to be done. But we have to remember that the locus that this blood type gene is located on, there's also other genes really close to it and next to it that deal with immune function as well. So I don't think this paper or this result really gives anybody the license to go out and not do the things that we've talked about: physical distance, mask, hand hygiene, not touching the face. It's a good observation. I think it lends to more studies. But again, there were still patients in the hospital that had the same blood type as everybody else who were still requiring oxygen and who were very sick. So I don't think, that paper in itself really just allows you to go out and not do the things that we've talked about, because everybody is still susceptible. And as we get further into this, we'll learn more about that. But it's an interesting observation, but I don't think it will change our practice in any way.
You and I have talked about this before when we've not been broadcasting, that this is how we learn in a medical community. These studies is kind of a compilation, and we're going to know a lot more when we clear this in many years down the road. Isn't that true?
Yeah, absolutely. And one study does not make guidelines. So we need to continue to assimilate and collect all the data that we can. This is very new. We understand that research papers come out every day, but unfortunately, in the time of COVID, we've also seen that a lot of the research is being retracted for one reason or another. Either the data wasn't valid or the way that they processed the data wasn't valid. So we need to continue to do this methodically and really look at everything and study it. Prior to COVID, that could be done regularly. It could be very well peer reviewed and could be debated upon to really come to the best conclusion. But now we are trying to find so much data so quickly and try to get it published for knowledge for the world to really overcome COVID, that sometimes some things get overlooked. And so we need to continue to get the data out. That's fine, but continue to review it and really validate what are the true results and what are the true data and what is it telling us.
We have lots of questions, and I just can't thank you enough in the community for watching and asking. I want to commend you. The questions are really good. You ask really, really good questions, and it's information that people need to know. And because of that, we want to let you know that every question we don't get to during the week, I'm keeping track, and we're going to try to go through those on Fridays. We're just going to dedicate that time to Fridays. Monday through Thursday, we will also always introduce the topic like we did today with Colette and with Jason. But I just wanted you to know we are going to get to your questions, and so please watch on Fridays or check back and look at the tape, or not the tape, but look at the feed on Facebook at a later time if you miss them. As we leave you, Dr. Hawkinson, in beautiful Colorado with the birds chirping and the sun out, what are your final thoughts?
Yeah, a couple weeks ago, we were concerned about the parties at the Lake of the Ozarks, the reopening. We had initially said, even 8 to 10 weeks ago, that a surge would come probably 2 weeks after that. Around the time of Memorial Day, we had figured, well, we actually think the surge comes later, 4, 5, 6 weeks out from those events and from reopenings. And that's really what we think we are seeing now around the nation, as well as locally. So I think we need to continue to reinforce the fact that the virus is out there in the nation. The virus is local in Kansas City. We need to continue to do those things this weekend and beyond that help reduce the spread. And it's really up to every individual to do those. Continue to physical distance. Be outside if you can. Wearing your mask to help protect other people in case you do have the disease. The mask may also offer you a little bit of protection. Use hand hygiene frequently and try not to touch your face as much as possible, especially to manipulate your mask. So I think those are the things to remember as we move into the weekend and beyond.
Well, and kudos to Colorado, too. You said that they had a really good overall practice of wearing their masks, right?
Yeah, you know, in the places that we've been, there's an excellent mask and hand sanitizing culture. All the restaurants, if you can't be inside, certainly need to wear them. All of the wait staff and all the people in the shops and the restaurants are wearing masks. There's hand sanitizer available. It's a very good culture. I think we need to continue to make that culture shift, continue to reinforce our points, because moving forward, COVID's going to be here. It's not just going to go away. Hopefully we can get, really effective treatment and vaccination. But right now, it's not there. We all want to get back out to concerts, to sporting events. And so the way moving forward is really to continue to protect ourselves. And by doing those things to protect ourselves, we're also going to be protecting other people.
All right, thank you. As always, we appreciate it, and we will check with you and hear from you from Colorado tomorrow.
Okay, yes.
All right, see you then. All right, back here in the studio, I want to turn to you, Jason, and to ask you, what makes you most proud about telehealth? What do you want people in the community to know about telehealth? And how is it helping in a time of COVID?
Yeah, thank you. Great question. I love that question because I, since COVID, have used telehealth myself to connect with my physician. For a number of reasons, it has allowed us to physically distance. It has allowed us to not put patients in close areas. A lot of patients are worried about just even getting in their car and coming to the hospital when they realize after their encounter they just had a conversation with their physician. We have had almost 80,000 visits in the last 3 months, specifically just for telehealth, telemedicine. And that is an amazing number. I was on a call yesterday with a health system in Minneapolis, Washington State, as well as New York, and they are asking questions of us. How would we do it? How did we get this done so fast? I'm having many conversations with our providers here in the organization, and they absolutely love it. We're seeing our patient satisfaction scores go up, with patients just really pleased with the encounter that they're having here. I encourage everyone. I've gone through it, so I've seen the fruits of the labor of the work that we've done, and I just really think that this is something that we're going to be going with forward for quite a long time. I think it's here to stay, and I encourage everyone who's afraid, who's been putting things off, to reach out to their care provider and see if they can do something initially with telemedicine, telehealth, through video, through chat, through phone call, and just start the conversation again with getting back to see your provider.
Well, and I know the other added benefit too for here or any healthcare place across the metro and greater Kansas is with the telehealth, then it makes less population or footprint for those people who need to come on campus.
Yeah.
And they can, and it enables us to socially distance and direct room. And I think we're finding that. We've talked with the chief medical officers at other hospitals across the metro. And so it's really very kismic.
It is. We're seeing patients, who have normally a 4-hour drive who don't have to do that for their care. And, on average, we were seeing, around 2,000 patients a day through telemedicine. That number has continued to stay strong in our organization. So I think physicians have really taken to it and realized they can give great medicine through video as well as through audio that we weren't doing, prior to COVID.
And it leaves a lot of room in these clinics for people that need to come in and have a doctor
Absolutely.
have hands-on.
You're exactly right. That's
Right.
exactly right.
All right, Jason, so thank you so much for taking time.
You're
We know
welcome.
we're really busy. Colette, what is the most frequent question that your team is getting as it relates to COVID?
I think two things. One, is it covered? And again, like we have talked about for years, Jill, get to know your insurance policy. You own that policy. Call your insurance provider, check with your employer, make sure that you understand your benefits. And I think the other one is, what are my options? I need help. What are my options? Call us. We're here to help you in any way that we can, and to understand that you may just be in a whole different place today than you were even a week ago. So I think that's the other question we get a lot is, how can you help me?
Yeah.
And know that we're here to help.
I know that with COVID, a lot of times when a trip to the emergency room happens, it is emergent and people need help and they don't always have a chance to pick
Right.
which emergency room that they want to go to. But in a time of COVID, knowing which emergency room is in your network is probably
A
smart.
good thing to know, yeah.
Yeah.
Absolutely.
Helps you make great choices.
It does help you make great choices.
When you're not in a panic.
Exactly.
Right? Okay. Thank you. We appreciate you being here too. Before we go, I want to check in with Jessica Lovell to see if she's earned her Nutter Butter cookie yet. I think that there she is. She's still, I bet you haven't had your blood drawn yet. It can't be that fast, is it?
I know, can you tell? I'm not woozy, I'm nothing, I'm great. I just had my finger pricked, and I answered some questions, and I'm just about ready to walk over and get my blood drawn. They reminded me that I haven't had my blood drawn since I was in high school, so I need to be doing this. What is it, every 56 days you can donate blood. And so this is such a great opportunity for you to give back to the community. And most importantly, Jill, it's safe. I feel safer here than I do at a grocery store. So this has just been a really great experience. It's quick. Everybody's super friendly. Everybody's doing all the things they're supposed to be doing, social distancing, wearing the masks, spaced out. You can see over here, folks are already starting to come in and give blood. And so I'm about ready to go get this party started. So I'm going to check back with you here in a little bit. So yeah, and I'll get some cookies and I'll see you in the office.
All right. Yeah, we'll welcome you back. All right. Yeah, I think I'm going to try to go maybe tomorrow. And the blood drive here on campus is through Friday, I believe. I don't know if we have the graphic. There are some other
So now
news
what?
conferences that are, or not news conferences,
Sure,
rather,
sure,
but
sure.
blood drives that are going to be happening, I think, at Hy-Vee and some other places. I think we still have Jess kind of talking to. So, but you can see where those were on the screen, and we hope that you have an opportunity to either become a first-time blood, be a first-time blood donor, or go and repeat and do it. It's safe to do it, and that's what we're going to do. Tomorrow, I want to let you know that our topic that we'll be talking about, kind of a serious one, when we had to postpone procedures and surgeries in order to conserve our PPE, that left a lot of people in pain. And we're going to be joined by Dr. Dawood Sayed, who is going to talk about some perhaps unintended consequences and concern around opioids. And we're also going to be joined by the chair of orthosurgery, Dr. Bruce Toby, who's going to talk about different things that they are doing to try to help people not be in pain, get back to the OR safely, and how they're keeping an eye on the opioids and their use. Most importantly, I hope Dr. Stites is back tomorrow. I think I see him waving, yes. If you want to come on and say hello to your people, I know that they miss you and we appreciate it. And sometimes these things happen. You want to come and just give your final thoughts and I will relinquish the chair. I told him you're a doctor and sometimes you have to practice medicine.
Sometimes I have to go be a doctor. Oh my God. And I missed this discussion, and I apologize because you know what? I wanted to hear it. I thought I'd be learning a bunch of stuff. So anyway, Colette, Jason, thank you for being there. Jill, thanks for subbing, especially at the last minute. Sometimes that happens. What a big day. You know, I was looking at some information today, and I know you guys have probably hit this. I know Dana will probably say it. Dana, you look like you're closer to Kansas because the land looks flatter. Yeah. You got your Kansas shirt on. But the, just man, social responsibility, the numbers continue to go up across the country. We don't want you to have to pay for COVID care because we don't want you to get sick. And the way to stay sick is to stay safe. And the way you stay safe is to make sure you follow those pillars of infection control, because whether you're in Colorado, I'm going next week, brother, or you're right here in Kansas City, there's still no place like home. So stay safe. We'll be back tomorrow. We'll see you then.